Annyeonghaseyo. Unfortunately, that's the only Korean that I can give you. And welcome everybody to this Sculptra launch. Welcome, and thank you very much for coming and for your interest. And I would say it is a great time, a very exciting time in cosmetic practice, in cosmetic rejuvenation. We get so many more tools to get even better results in our patients, and one of those tools that you will have here in Korea available from now on is Sculptra. I've worked for more than 10 years in a private clinic in Switzerland, multi-specialty. There was orthopedic surgery, pain management, gynecology, urology, and aesthetic and reconstructive surgery. And I took care of the volumetric issues there in cooperation with a good friend, plastic surgeon. Now, this is an example of plastic surgery, and I have the highest respect for plastic surgery, and it has been published. And this is literally from that article. This is an example of dramatic results, and I think with dramatic they mean wonderful, produced by facial contouring consisting of upper mid-facial suspension, lateral brow and temple contouring, palpable eye shaping, malar augmentation, rhinoplasty, retidectomy of the lower face and neck, and you can see left the pre-operative and right the post-operative outcomes. I can say only to you, congratulations, Korea, with having Sculptra, because you can do it now with a needle. Sculptra is really a product what is in its way unique because it can address pan-facial shape, contour and volume in a face with relatively small amounts of product. It's not a filler. You can't use it as a filler. It is a product that when you inject it in tissue, it will regenerate collagen. And the collagen gradually will give you volume. That is the difference between a collagen stimulator and a replacement filler. Mode of action is collagen stimulation, and the effect is gradual and never immediate. But again, they are able to offer considerable pan-facial augmentation in a cost-effective manner. It's a biocompatible and immunological inert synthetic polymer. Basically, the ground component is vegetables, the lactic acid, and it's synthesized into a polymer. The polymer is slowly hydrolyzed to monomers, and they are then metabolized to carbon dioxide and water and eliminated by respiration. It's a gradual breakdown in the system. A little bit about the history of PLLA. It's not something new. Polylactic acid was synthesized in France in 1954 and used especially in surgery, in braided and monofilament sutures, but also craniofacial surgery and orthopedic applications in screw, plates and membranes. And in that time, they already observed an influence on tissue from the polylactic acid. In 1999, the product became available on the European market as a microparticle product in a watery suspension for injection, but was put on the market as a dermal filler. We were not aware at that time that actually this was the first representative of the new group, as we know it by now, the group of collagen stimulators. And you can imagine that using a collagen stimulators with the technique and the methodology of a dermal filler is not right. It's like if you want to drive with your car here on the Han River. That doesn't go, you need a boat. So we learned a lot from that period. And thanks to many other colleagues in Europe and other parts of the world, we had a Vega study in HIV patients. And then, of course, when it got acquired by a US company, Dermic, there was further investigation and data collection about the product. But finally, as Dr. Kim said, in 2004, it got the approval in the US for HIV, in 2007 in North America, Canada for cosmetic, and in 2009 FDA approval. Since it's such a real unique product, the company decided to formally install a training program for core specialists. Not that it is a difficult product, but it's a different product. And the methodology is different. If you know the methodology, if you understand the product, you have very well and beautiful and predictable outcomes. If we look at what we learned, you can see that using a new group of products, collagen stimulators, in a way as a dermal filler has disadvantages. And that's what we saw in the Vega study. There were very good volumetric corrections in HIV patients, but also a considerable amount of nodules and papules, which were irregularities. Most of them were not visible, but palpable. But you can also see that when we started to understand the product and knew that we had to use much less concentration, that we had to reconstitute it in advance, that we had to use a different type of needle, that we had to inject it either in the subcutaneous space or on the periosteum, and that we had to do it in small quantities, and that we had to advise the patient to massage, that all these issues were lowered significantly. Not only in the pivotal trials like the Vega, Chelsea, Westminster, the safety studies, the Blue Pacific and APEX studies from the US, the 301 cosmetic FDA trial, but also in experience and publications from our colleagues, from Dr. Ute Bauer, plastic surgeon in Italy, Nelly Gauthier from France, with considerable amounts of patients, myself, Dr. Nick Lowe. It is a consistent lowering of papules and issues that we saw in the beginning when we used it as a dermal filler. I think nowadays the best you can expect in experienced hands with any product that you inject, that if you do a very meticulous proactive search in your correction, whether it's collagen, hyaluronic acid, Sculptra, radius, you always will find in 1% a little irregularity. And that's just the way tissue works. But that's acceptable. But there is not really any difference anymore between Sculptra and other products in terms of their adverse events. And actually, the neocollagenesis on Sculptra has been described on many occasions. This is just work from myself, published in 2004, where you see an implantation of particles. On this side, the particles are already in degradation. They are already, let me see if this, they're already fragmenting. You see more mature collagen around it and very young early collagen fibers throughout the aggregate of particles. After 30 months, what you see is an abundant amount of mature collagen, nicely integrated in the tissue without disturbance of pre-existent architecture, and no particles left anymore. We only start to understand now that the fibroblast is very important in this whole process and that you need a certain amount of healthy fibroblasts. We learned from work like Fisher very recently that fibroblasts are funny creatures. As long as they live in tissue with some collagen, they kind of hang in that collagen and they're stretched and they're happy and they produce collagen and their collagenase levels are low. When we're getting older and when we are losing our collagen, those fibroblasts, they lose their connection and they collapse and they become sick. And what they do is go on a sort of suicidal mission. They stop producing collagen and they are increasing their production of collagenase. So the little collagen that is left is eaten up even quicker due to the fibroblast. And I think this is probably one of the handles where collagen stimulators are getting in. By slowly, gradual restoring collagen amounts in the tissue, you also probably revive the fibroblast, and they start producing more collagen, but more especially, more important, they stop producing those collagenase levels, which actually accelerates breakdown of collagen. If you look at the performance of PLLA Sculptra as a collagen stimulator, and this is from the 301 study, you see that there is a gradual improvement, in this case in the wrinkle assessment score, which was significant at all time points. And you see that after a certain period, there is a very stable correction up to 25 months. You still see that at 25 months, 2 years, the correction is stable. What we can say to our patients that it lasts 2 years is because the study closed there. But in clinical practice, we see that at least the correction will last 2 to 3 years, because probably after 2 years it slowly goes down again. The gray lane here is the comparative, that is the collagen. You see, if you inject collagen, you get an improvement in the wrinkle assessment score. Of course, you fill, but you see that the breakdown of the dermal filler, the wrinkle assessment score already drops down to baseline and stays there. So a very, very consistent performance over a long period in volumetric improvement of the product. Very consistent with what we already knew from 2003, how it acts in HIV patients. The same, although this was not a wrinkle assessment score, but they measured the mean skin thickness with ultrasound. We see that gradual increase in volume or thickness, and then that long stable period of result up to, in the Vega study, up to 114 weeks, which is more than 2 years, but still very stable. Another unique thing, I think, is the high percentage of satisfied patients, and this is from the cosmetic trial. You see that already in week 3, there is a very high patient satisfaction, but that high patient satisfaction is maintained up to 80% even after 25 months. Patients, 80% are still very satisfied with the result, and they judge their results as good, very good, or excellent. Also very consistent with what we already knew from the APEX and the Blue Pacific study from the US in HIV patients. Also very high levels of satisfaction with the correction. So some key findings of these pivotal trials or studies. There was a consistent, progressive, and statistically significant improvement over baseline in the cosmetic one. The overall incidence of adverse events was significantly higher in the comparative group, in the collagen group. There was more erythema, there was more injection site inflammation in the collagen group than in the Sculptra group. And the amount of nodules was for both almost the same, at least not significantly different. Still, based on the first days in '99 that we started to use the product as a dermal filler and had more nodules than we should have, still there is a little bit of a legacy about the product. There's still some degree of skepticism by some physicians, but I think that many users of the product nowadays will tell you that it is a very safe and performing and predictable product with the right methodology. And actually this is a quote from Dr. Nick Lowe, dermatologist from the UK. Probably you've heard of him, who writes about that in the journal of the EADV. If I show an audience 2 nodules, sometimes based on that legacy, and I ask which one would be the Sculptra nodule. One is the Sculptra nodule. A lot of doctors say this is the Sculptra nodule because it looks more severe. Actually it isn't. This is the Sculptra nodule, the one on the right, don't think the pointer is doing it. That's the Sculptra nodule. This is an hyaluronic acid nodule. It doesn't mean that hyaluronic acid causes more or severe nodules. It only makes the point every product can cause nodules. It's not unique for a product. And if you do an honest and extensive search in literature, and there are hundreds of articles, and I just show you two. If you look at the top 10, all the products are there. Silicone, collagen, hyaluronic acid, polylactic acid, article, all may cause nodules, swelling, or other issues. And if you look at these adverse events, one of them is Sculptra, there's one is collagen, there's one hyaluronic acid, there's one article, there is one other PMMA substance. What it means is if you use a product in a wrong way, wrong indication, don't know the technique, you may get these issues. And the nodule from Sculptra is this one. So, in all honesty, adverse events, whether it's nodules, inflammation, papules, granulomas, if you look in literature, all the products have them. And often it is caused through technical issues. Wrong level of injection, wrong amounts, wrong reconstitution or whatever. And that's why it's so important that we have to understand our products and learn how to use the products. Because nowadays, with a variety of products, you can't say if you know how you can inject Restylane, that you also know how to inject Juvederm or Voluma or Sculptra. No, they all are different, and they all are a little bit different to inject, and you have to get the experience to get the outcomes. Why do we get all these products? Well, we age in a very unique but relatively consistent manner, and we get that distinct and easy to recognize aged appearance. And it has a lot to do with volume loss, volume. We want to give volume back to the face. And we are more and more recognizing that changes of volume in the skin and the soft tissues such as fat and muscle, but also the skeletal support, that some greatly contribute to the changes in volume that we see in the aging face. So we start to realize that in rejuvenation, it is not only a question of getting rid of a couple of wrinkles. It is a slow loss of volume and contour and projection and dimension what makes us give an older appearance, not those little lines or wrinkles. So there is a paradigm shift. You see globally, we are all going that way, it seems. We're looking more in 3 dimensions to the patients. We are going from 2-dimensional aesthetics, focused on line and folds and wrinkles and dermal issues, to a 3-dimensional aesthetic where we focus more on contour and form and harmony and projection, convexity. This is what we want nowadays. You can see that those patients still have nasolabial folds. These patients, treated according to the old 2-dimensional aesthetic view, got all treated in the nasolabial folds, and they all lost their nasolabial folds. But you can't really say that the patient there, that she looks like young and healthy and full, and she just doesn't have nasolabial folds anymore. And these patients still have their nasolabial folds, but they have their volume back, and their contour, and their shape, their oval or heart form. And I think that most of us are starting to appreciate that that looks more natural, better, etc. Because nasolabial folds is very human. It is a typical feature of a human face. Getting rid of nasolabial folds is not natural. We need to have nasolabial folds. Even icons of beauty have nasolabial folds. And imagine that for decades we have spending almost all days in our office to getting rid of these folds, and actually they're very natural and they have to be in that phase. But if you still want to get rid of nasolabial folds, you have to consider that the only species, to my knowledge, who really doesn't have nasolabial fold is this one. They don't have nasolabial folds. When I do a Sculptra treatment, or actually any treatment, sometimes someone who is looking says, oh, that's easy, or that looks easy. Why is it easy? Because the injector was able to define the problem. He knew what the problem was, and he was able to define the cure. What product? Where do I put it? Do I put it deep? Do I put it in the dermis, under the dermis? Do I put it on the bone? What was the problem? Volume. When volume was it lost because of fat, deep fat, bone resorption, whatever? And he had the skills to do it. Often with new products, we all are very focused on number 3. We want to know what size needle, what dilution, how much do I inject? But if we are not able to define the problem in a phase first, and then define the cure or the treatment, on what level do I want to inject and where, then we will never start doing these treatments because we don't feel comfortable with it, despite the fact that you may know the needle size that you have to use and the amount you have to inject. So let's go through these problems. Now, nasolabial folds are more symptoms. If you consider the skeletal platform as the table where you're sitting on, and the soft tissue as the tablecloth, and those are beautiful tables because the size of the table is exactly fit for the tablecloth. But for example, a young girl of 13 years old can already have very prominent nasolabial folds in case of a congenital maxillary retrusion. In other words, when the table is too small and there's too much tablecloth or soft tissue on it, and then it accumulates. So in younger patients, nasolabial folds are often signs of skeletal insufficiency. And if you see nasolabial folds in younger patients, especially at the site where they are the most prominent, probably they have an issue there with surface or height of the upper jaw or maxilla, or maybe they had dental issues, or that's the way they were born. We all know that when we are getting older and we have more volume in our face, we look better. So who thinks the one on the left looks better? Who thinks the one on the right looks better? Most, okay. So we like volume, right? What could this be a treatment? It is to establish the importance of volume. It's no treatment. Actually, they're two sisters, twins, and the other is just more heavier. She has more volume. And we like the one who is heavier, who has more volume. So we like volume, but it has to be in a natural way, in the right place on the face. What part of volume is important? What tissue gives us the volume that we like? Is that the skin? Does the skin gives us the volume as in this? Is it her skin that is better, giving her more volume? Let's have a look. Senility of the face is changing in many tissues: fat, skin, muscle, and skeletal platform. If we look at the skin, and you see here one person, and on his left side, the driver's side, when he's driving, and the sun comes in, you see he has a dermal atrophy, sun damage. And it doesn't really make a lot of difference, although his dermis is thinner, for his volume. It's not that the left side is much less volumized than the right side. The difference that we see is that the side on the right, where the skin is better able to control deep volume. His nasolabial folds are less heavy, his marionette lines are less heavy, the volume from the orbits are much less bulging out, so the skin is better controlling in volume. But it doesn't really make a lot of difference for the total volume of both sides. So skin, important to give form to volume, but not to give volume itself. Fat compartments. Thanks to Roach and Pessa, we learned there are many fat compartments. They are compartmentalized, they don't communicate. We have superficial fat and we have deep fat. Is fat important for a nice young looking face? I think so. Fat is important, but is it the deep fat or the superficial fat what is important? In other words, is it the fat on the skeletal platform behind the muscles, or is it the subdermal fat what is important? Well, if you take the dermis away on a cadaver, you still see that there is a certain volume in the face and that there is a certain contour. So the skin is not really important for volume. Even if you take away the superficial fat and the SMAS, you still see a certain volume and a certain projection of the face. Only if you start to take out the deep fat, then you see that the face totally flattens. So probably deep fat is more important to have deep volume fat to look nice and young than dermal volume or subdermal volume. The distribution of deep and superficial fat is also different when we're young and old. A younger person has the same amount of superficial fat and deep fat. In other words, the same amount, more or less, on both sides of the muscle. And when we are getting older, we lose that important deep fat which lies on the bone, and we accumulate superficial fat which lies above the muscle. And that has consequences for muscle function. If a young person smiles, it's a wide rolling smile. If an old person smiles, it's a kind of contracted smile with superficial fat. And the muscles work differently. Muscles in young persons, they lie over deep fat, and when they contract, they do this. They kind of contract and pump. They're curved. And when an older person smiles, the muscle is straight, there's no fat underneath, and they contract. And they kind of bulge that superficial fat, and you have this. So if you do corrections, keep in mind if you use a lot of dermal thickening or subdermal volume here, when people smile, they smile like old people. So deep volume is really important for a natural appearance. Superficial fat has probably a protective and metabolic function. It may highly fluctuate with your dietary state. And deep fat is much more stable. It's more sensitive for aging and not dieting. And it has a mechanical function. It lies behind the muscles and it makes the muscle curve, and it kind of has an effect on their physiology. If a patient tells you, I started to look old and I got all these folds because I did this diet, it's not true. Don't believe it, because loss of superficial fat may accentuate a contour, a deformity, or a fold, which was already there, but it doesn't cause it. Deep mid-facial fat probably is the primary determinant of a youthful, anteriorly projecting mid-face. So fat is important to look young, healthy, attractive. How about the skeletal platform? You can see in these pictures of Sean, there are many other studies about it, that there is an enormous change in the skeletal platform, where as we are young, we have a huge amount of zygomaticus bone here, and look what's left when we are getting older here. Look at the orbits, nice and round, and you can imagine that the insertion of the orbicularis oculi retention ligament here and the support of the lower eyelids of that bony orbital rim here is very nice. But when we are getting older, we lose all that bone there. And that whole suspension, retention, and that support of soft tissue is gone, and the eyes, the soft tissue falling back. Look at the upper jaw, huge mountain of bone there. And what is left when we're getting older? Little flat area of bone. That's why we get all these long upper lips when we're getting older, because the upper lip usually hangs over that bone like this. And when we lose that bone, it just falls back to the skeletal platform and it's long. So often there is a confusion between lip lengthening and lip thinning. For lip thinning, you do lip augmentation. To shorten the lip, you have to inject on the skeletal platform, put volume deep behind and curve that lip again. And then you do real good rejuvenation. Whatever study you look, this one, PESA, or the Lambros algorithm, or Richard Morris, a retrospective review of CT scans, they all say the same. There is an enormous change in the skeletal platform, and apparently that already starts when we are 25 years old. Then it starts already going worse and worse. What are the clinical consequences? This is a photo that we used in an article from that we wrote about the dermatological implications from an article from PESA. You see that an infant has a very little table, very little amount of bone, and enormous amount of soft tissue fat. So there's no definition. It's all like propped up. There's no jawline definition. They have jaws. But if we grow and that table, that skeletal platform is growing, that soft tissue get nicely spread out over that area, and you see that the lip, for example, get the typical young ratio of 1/3, 2/3. What I mean is from the nasolabial crease to where you close your lips, and then from where you close your lips to the edge of the mandible, in a young face that is 1/3, 2/3. When you lose all that bone here, and that lip falls back down, it goes back to 1:1. So anything that you rejuvenate in the face, taking away lines or folds, but you still have that long upper lip as long as the lower part, looks funny. If you can look through the skin on the skeletal platform, and you almost can't do that in a patient with HIV and in an older patient with hardly any fat, you can see that despite the fact that the young patient lost a lot of or most of his fat, he still has a very strong projection of his facial features. And that's all bone. That soft tissue, that skin is supported by bone. But look at the old man. The old man has lost his fat, but also his bone, and it's all flat. So bone is enormously important. It is the table where everything is spread on. And notice that young guy, despite the fact that he lost all his fat and also his mentalis fat, he doesn't really have a tear trough or hollow eyes, because there's so much bone here. What is retaining these soft tissue structure that you really need also to lose a lot of bone to get tear troughs and hollow eyes and dark circles. And that's exactly what you see. A young orbit, well supported, tear trough is a normal anatomical border. And everybody has that. Only when you start to get older and lose that bony support here, then you get that lengthening of the tear trough and aligning with the lid-cheek junction, and then it becomes a cosmetically unpleasing feature. Very well captured in the animation of Lambros. He has many of those. You can see all these things happen in the same person. Bone resorption, expansion of the orbits, lengthening of the lip, loss of height of the upper jaw, lipoatrophy. But if you look at the blue arrows, those are a couple of dermal landmarks, they don't move a lot. We have the impression that his face is sagging, but actually deflation sometimes suggests sagging. But if you look at dermal landmarks, it's not really sagging, it is deflation what's making him look so old. So the skeletal platform is very important. That is what defines the form and the support of the soft tissue. So we need to know about the skeletal platform. Therefore, we need to know the specifics. Now, is this a man or a woman? Who says this is a woman? Who says this is a man? Slightly majority for the man, okay. Or can't you say, is it too difficult? Do you have to do measurements and weight? And no, it's very easy. This is a woman. A man looks totally different, the skeletal platform. Men have much more blocky and massive upper face, as you can see here. They have sloping foreheads. Women have round vertical foreheads. Men have much more rounded and dull lateral brow ridge and also superciliary arch. The zygomaticus bone of men is much larger. Men have more lateral prominence, more cheekbone, and the mandible is more squared and larger. And also the upper jaw, the maxilla, is much larger. Why we sometimes say that women have more cheekbone or higher cheekbones is because we are looking at the combination of deep midfacial fat with zygomaticus, malar region, zygomaticus bone, and lateral zygomaticus bone. But in terms of bone mass, men have more bone there than women. So in male faces, typically the widest point is here with a lateral prominence, and in female faces it is more a lateral prominence with a more anterior projection in the midface due to more subdermal fat and a bit more deep midfacial fat. Men are very flat in this area. But you can see the soft tissue is actually mirroring, reflecting the form of this platform. If this skull would have been a pyramid, his face would have looked like a pyramid. And that's something you can change with volume injecting on the bone. We also age different. Women have very stable skeletal structures here. They stay white. But their soft tissue around it is very unstable. So a typical female aging of the upper face is staying white in skeletal structures, but become very hollow because the soft tissue is disappearing. In men, it's the other way. Men have very stable soft tissue, but very unstable skeletal structures. So men keep their soft tissue, but the skeletal structure is becoming narrow. So men stay straight, vertical, but narrow. Women stay wide, but become hollow. And then the lower face is also totally opposite. The mandible, when we're young, in men and women, both has a certain angle. When women are getting older, the angle is getting smaller and smaller, or sharper and sharper. And the mandible rotates backwards. So the mandible goes backwards and becomes sharp. In men, the mandible, the angle, becomes wider and the mandible goes forward. So we become very prominent there. Maybe a reason why we see more issues of soft tissue in women in an earlier stage of life than in men, because in women the bony support is really going back, and in men it's only pushing forward. So there's increase of support of soft tissue there. Why do you have to know all these things? Because if you go in three-dimensional cosmetics, if you want to re-volumize a face in a natural way, you have to understand what is normal. Where did you start as a young person, and what happens when you get older, to be able to reconstruct it in a natural way. And that's where we are going to. And that's what patients also see, what is possible, and what they start to demand from us. And that's where the collagen stimulators find their place in the cosmetic arena. Whether you like it or not, collagen stimulators, they're here and they will stay, and there will be an increasing demand on using them. A celebrity, typical male pattern of aging, you see he already had kind of long chin when he was young. He only becomes more prominent. When you get a male patient in your office, don't do too much here. A male needs it in his temples. Widen it out in the whole temple area, from here to here, because it has to stay vertical and wide. In women, where it's hollow, you do it in the center of the temples, you create volume, and you create a dome, a roundness, because that is typical. And if you confuse those two things, then you may look a man like a woman or a woman look like a man. They will not be satisfied with what you did. That's what I can assure you. Why? Because giving volume changes contrast and light in a face. You can imagine if you have a high elevation that reflects light. So if you look at this person, your first thought, is this a female or a male face? Who thinks female? And who thinks male? And this one, is this a female or a male? Who says male? Female? And a male. That's what we think. It's the same person, but different light. Our brains work if we see a lot of contrast, a lot of difference between the lightest point and the darkest point. Our brains are suggesting to us that is a female. If we see little differences between light and dark areas in a face, our brains are saying that's a man. So if you give a lot of volume in a female face, but all over, so that you don't create highlights, then she paid a lot of money for what you did, but she doesn't look as a female. She still has a sort of hard or masculine thing over her. If you do the same in a man, you give a man volume and you put it all in one place, and he has to pay a lot of money for what you did. He's not happy because you made him look like a woman. Those are very, very tricky things, pitfalls. Keep in mind that there is a difference. Why? It's our brains. You can't help it. You can't control your brains. Translator, can you say that again? The audience can't control their brains. Nobody can. Because I will show you this. This is a patient. Imagination. It's a patient. And it's a female. And she comes to your office. And she says to you, doctor, my cheekbones, this, the B, the cheekbones, they're up here. And this is the mid-canthus, the A. That's probably her nose. I want to enhance my cheekbones and I want to pay a lot of money, and you may use as much product as you want. Because I think that looks nice and young. And that's what you do. So you give a lot of product above and higher up at the orbital rim and underneath and more lateral and then medial and then in the tear trough, and you use a lot of product. What changed on her cheekbones? Did you do good or right? Can you get that light out? What did you do? Is it a good or a bad correction? Did you see what happened? I don't think you saw what happened. Your brains are doing this. Nothing happened, but it looks like. Look at the B. Look at the difference between the color of A and B. This is how it looks after you corrected her. And this is how she came in. You see the difference between the B and the A? This is much lighter, and that's darker. Nothing changed in this slide in color. Nothing. It's the same gray, but your brains are making it different. So actually, what happens? You put a lot of volume there. You lowered the contrast, and she looks like a man. Be aware of that. Light is something that magnifies what we do. You can never blame light. Oh, it's because of the light that it doesn't look good. If you did good, the light will magnify that. If you did not good, the light will magnify that. If you look at this, rumor goes that she's staying in this hotel today. I'm not sure if it's true. you see, light is magnifying the way we look. And it's not making us look that way, it magnifies it. And in men, if you do a wrong correction, you give a lot of contrast. These are all men, and they got a lot of volume. The only problem is they got it in the wrong place. Huge anterior projection, a lot of contrast. You all look very feminine. We don't like that. And there is a perspective of beauty in Europe and in North America and in the Middle East and in Asia and in Korea, and it may all differ. And there's a huge controversy about what is nice, what is attractive, what is beautiful. But Bashir did an enormous literature search. He looked at thousands of articles of beauty. And despite all the controversy, there were 4 things that everybody liked as attractive. The Asians, the Americans, the Europeans, the Middle Eastern, 4 things where they didn't dispute about. That was youthful, which is volume, averageness, normal averageness, not huge cheeks or huge lips and an old face or tiny little nose, average, and symmetry. And sexual dimorphism is what we mean, respect the form of the male and the female face. Don't make a man look like a woman or a woman like a man, because we don't find that attractive. If we accentuate female features in a female face or accentuate male features in a male face, we like it. This is where we all agree on. This may happen if you don't respect that. This is not average. This is a patient who comes in, totally blind. What she had tear troughs. Everybody has tear troughs. It's an anatomical border between the medial side of the orbicularis. She had a little bit of lid-cheek junction. And the doctor could not resist her persistence of getting volume in the midface. So he gave her so much volume that it looks almost like her midface is exploding. But you have to give that amount of volume to get rid of a normal anatomical border, because it was no issue of aging. It was just the normal tear trough everybody has. And you have to be aware of that if you correct one area in the face, although it may be technically okay, it may look absurd. That patient has temples like a 50-year-old woman with temple atrophy. She has a very manly jawline. She only wanted to have cheekbones. If you do it as a doctor, this is not a commercial for your practice. So be very critical what your patients want, because patients come in with, look doctor, you see this movie star? I want to have her nose, or I want to have her lips, or I want to have her cheekbones. Okay, here you have her cheekbones. Wonderful. Joan Rivers, another thing. These things are never done intentionally. No doctor does this on purpose. Did she have surgery? I don't know. I don't know her medical record, but let's have a look. I think her lateral volume is a little bit too high than what you would expect for her age, so maybe she had a facelift or a repositioning of volume surgically. What I do see is that her nose is kind of still up-rotated, upwards. We know that when we're getting older, we have skeletal rotation downwards, and actually her ratio from here to here and here to here is 1:1. So this is telling me she had a clockwise rotation of her skeletal structures. But her nose is telling me different. Her nose is telling me that it went upwards. So often if you do these kind of over-rotating rhinoplasties, you have to almost provide volume also here deep on the skeletal platform to change the ratio of the period or region, because it doesn't match. And then someone puts a lot of volume there at random. It looks like she's growing a submental fat compartment. It doesn't fit. We see her chin is aging as it should, but her midface is only getting younger and her nose is only getting more up. these things don't happen on purpose. And a lot of times several doctors are doing that. And then the one doctor says, you know what, this is okay, but you need volume here. They forgot to put volume here, so you put volume there. And you got this. So then you create the mandible of an aging man. Averageness, averageness, averageness. Know what is typical female and know what is typical male. A lot of people think this is an HIV patient. It isn't. It's a patient with normal fat amounts. He just has not enough bone. So we need to feel, examine our patients' faces as we used to do in medical school when you had to listen to the lungs and feel the liver and listen to the heart and etc. You feel the face, feel the bony structures. This is something the surgeon can correct with implants. If you put the implants there, you see that actually he has normal soft tissues. They were just not well supported and projected by the table. So it's a bony issue, a hard tissue issue. We can kind of recreate these corrections now with collagen stimulators by injecting on the bone here, and here, and here, and here. What is the power of deep volume? You see he has a very squared, blocky face, typical male. Even if you put deep volume on the bone, you respect that squareness. You don't make it into a balloon. Deep volume will never cause a balloon, a round face. It always respects the form that it had. Only if you give a lot of subdermal volume or dermal volume, then a face starts to balloon. You can see he still has some lateral lipoatrophy on the right side, so he went to another doctor, wanted to have some lipoatrophy here. For whatever reason, they decided to put a lot of subdermal volume all over his face, and you will see that you lose control over the shape of the face. So deep volume keeps the face squared, angulated. High volume makes the face look like a balloon. So if you have male patients, you often only inject very deep on a skeletal platform. If you have female patients, you do it deep on the skeletal platform, but also in combination with some subdermal volume. This is a young patient also with an issue on that side of the skeletal platform, but the other issue has that his skeletal platform also doesn't have the configuration, the form of a typical man. He looks a bit feminine. And those patients may walk into your office and ask for Botox or whatever, and that's not what it is. There is insufficiency of the skeletal platform. These patients need deep volume. So if you give him deep volume in his temples all over to make it wider and vertical, you give him some lateral prominence, and you inject here with a collagen stimulator on the periosteum of the mandible to create some width, some wideness, and some angulation, you will correct him in the right way. But therefore, we need to know all that anatomy. This is after one treatment. It's already looking better. And this is after 2 treatments. So you see with deep volume that you can restore form and volume in a good way without making someone look like a balloon or like a woman or a woman like a man, etc. But that's why we have to know the anatomy of aging and how volume works. And this is an aging man, and you see an aging man, we are already prominent here. We don't need volume here. We need volume here, man. We need to widen out in the upper face. Deep in the temple fossa is very easy, it's very safe. You go straight through the temporalis muscle. When you touch almost bone, you give little depots of 0.3 milliliters of a 9 ml dilution of Sculptra in a row. And you do it 1, 2, or 3 times, depending on the volume loss. So it's a very gradual, sneaky change into an older age. And all the tissue layers are affected. And you have to develop the skills and the eye and the subtlety to see the opportunities. Because often doctors think Sculptra is not a product for young patients? It is. It's much easier in younger patients because they respond well, they're little bit stimulation and they're already okay. Do a facial mapping, feel the tissues, feel is there a lot of bone, is there fat, how is the skin? Then you get an impression of where to put volume, deep or not deep. Evaluate. So if you want to keep it simple, and we see more and more younger patients coming in our offices, and they don't have the typical wrinkles and folds, but still they're not happy. They think, I'm not happy the way I'm looking. And if you want to make it simple for yourself, you can think two ways. Okay, is this a hard tissue problem or a soft tissue problem? In other words, is her table okay or is her tablecloth okay? Who thinks this is a hard tissue or a bony issue? Who thinks this is a soft tissue problem? Do you remember that article that I showed from why children, infants have jaws, that little baby face, that little tiny skull and all that baby fat around it? She looks a little bit like a baby, right? With a lot of soft tissue. She doesn't have enough bone. She has a lot of soft tissue, fat, skin, but not enough bone. So it's kind of propped on a small table. So these patients, you can help them by giving them deep volume just on the bone. Make the table bigger and spread the tablecloth. Very simple procedure, 15 minutes, once or twice, with remarkable results. You can see her whole face looks more mature, like a mature, not that baby face is gone. Not dermal thickening, no treatment of nasolabial folds, just deep volume on the skeletal platform. You can read about this in a couple of book chapters we wrote about it, and in a very recent article Dr. Kim already said. So if you see this patient, and you can look it online if you're interested, this is the reference. It's from a CME program, what I did with Dr. Fitzgerald. We do a lot of medical education. If you look at this patient, is this a bone problem or a soft tissue problem? If she comes into your office, doctor, I'm not happy the way I'm looking. What do? I don't know. She doesn't have folds, she doesn't have wrinkles. Is it her bone? Is it her soft tissue? What is it? Who thinks it's her bone? Who thinks it's her soft tissue? Okay. It's her bone. There are clues, and I showed it in the previous slides. You remember that 13-year-old girl with the nasolabial folds and the maxillary retrusion, congenital? Look at her face. This eye is higher and wider than this one. This is kind of asymmetry in the skeletal platform. This nasolabial fold, nasolabial crease, and the length is much deeper. So this side of the skeletal platform is different than that side. Look at the prominence and the height of her zygomaticus bone. It's more prominent and higher than on this side. She has an asymmetrical table. She has a table which is kind of this. So what the easiest thing you can do is create some collagen or stimulate some collagen here on her lateral cheekbone to make this look even. Inject a little bit here in the temple to pull a little bit her brow here and here. And then inject on this side, on the upper jaw, to kind of push this forward. And then she has a perfect symmetrical face and there's no tissue. Her soft tissues are okay. She's young, they're thick, they're not old, they didn't age. It's a skeletal issue. Look, you can see the whole clip and explanation online. If she comes into your office, doctor, can you do something for me? Is this hard tissue or soft tissue problem? soft tissue. If you look at her nose, her mouth, her mandible, she's quite symmetrical, but looks, she has no fat hardly here, and all her preauricular fat, lateral fat, and even cheek or lower cheek fat is gone while she has her cheek fat here. Easiest way what you can do is one side, fill the temple, fill the preauricular fat, and then you're done. That's the way to analyze a face, and don't forget the temples, because the temples really makes an enormous difference in the overall appearance of a face. It's very easy, it's very safe, it's quickly done, it doesn't need a lot of stimulation, and it has an enormous effect on the overall shape of a patient. Here's another patient, and this is probably the concept of, or attractiveness, which is cultural. This is a patient of Asian origin, grew up in Western society, Europe, United States. I have the impression that in the Asian countries that from here to here would be enough. When you're kind of westernized, the Western attractiveness is a bit fuller, more projection, so you go more to mid-face projection. But you see that a little bit of volume, and it's only 2 treatments of some deep injections in the temples, a little bit here in the deep medial cheek fat, then subdermal volume on the cheeks, and a little bit here on the chin, already makes her face look much softer and nicer and more at rest. So it's not always difficult, and it's not always a lot of work. You only have to look different to faces. And here you see the side view of this patient. This has been described in an article recently. Dr. Kim mentioned it in the Journal of Dermatological Therapy. It's an extensive article, 26 pages, with a lot of photos and technical positions of the needle, explanation where you inject, how deep, why, with analysis of the face, etc. Piriform aperture, the surgeon puts implants there and pushes the nose up and changes the lip. We can do it also with an injectable by creating collagen there, because if you inject under the nasal alar where the surgeon is putting its implants there, create height, look what happens. Even in an older person, her nose goes up, she starts to pull up her lip, and she starts to show more mucosa. Very simple, only perpendicular approach. Think about the angular artery underneath, and then a small depot on the periosteum. That is how you change position of nose, lengthening of the lip, and the ratio of the perioral region. Not with lip augmentation or thickening of nasolabial folds. You can do this. You have to do it on the skeletal platform. We know from Roach and Pessa that if one area changes, sometimes negatively, another area changes. It looks like if we improve one area, that more areas are getting better. This young patient only got an injection under her nose, and you can see that not only the curl of her lip, her anterior projection, but also the lid-cheek junction improved from that one simple site-specific augmentation. Here you see an approach, also described in that article, of the canine fossa, where to inject and what kind of precautions to take. With one of my patients, you saw her also in the clip, I think. You see, it is according to the standards of attractiveness, it is youthful, it's volume, but it's average. It's not one area enormous and another area not. It's average volume all over the face. And she has a slight asymmetry on her chin. It's not so visible on the view, but if you push tissue, soft tissue from here, through an injection here, behind the muscle, push this forward, you get rid of asymmetry. So the new approach, deep injections on the periosteum, not in the nasolabial fold. The marionette line is the depressor anguli oris, which lies in the area of lipoatrophy lateral and posterior rotation of the mandible medial, and reveals itself. In women, it's not hypertrophy of that muscle, it's just this area and this area are getting lower and the muscle stays in between. So you inject behind the depressor labii inferior or mentalis and push soft tissue forward, and you treat lateral lipoatrophy. You inject here on the periosteum of the mandible, and then you get that conversely positive effect with 1, 2, 3 areas. It looks like the whole face changed. This is where you can see the asymmetry on the left side of the mandible. Her mandible is just angulating a little bit more. If you inject a little bit more on this side, you correct that. When to start? Again, if you have a young patient with certain issues, not enough bone, not enough height, not enough fat, or a combination, I think the sooner you start, the easier it is to correct it, and it's more cost effective than delaying initiation of treatment. Collagen stimulation is really a good option for young patients. Patients prefer treatments who have a good longevity. There has been several polls, but if you ask them, do you want a treatment with immediate result, but only for 1 year? Or do you want a treatment which has a gradual result, like 2-3 months, and we have to do it once or twice, but for more than 2 years? That 75% in one survey and more than 90% in the other survey said, okay, I take the gradual one if it gives me 2 or more years result. With age, we know everything is changing, so remember that the time and the amount of any product or procedure that you have to use or that it takes to achieve an optimal result is contingent on the quality of the tissue. The longer you wait, the more you have to do, the less natural. And that's why we have to develop our cosmetic look, our way of looking at faces and understanding and recognizing early signs of aging. Because our patients see them and they come to us because they're not happy. And if we don't see them, we send them away. We say, well, come back in 5 years, then maybe I see it, but it's already there. Another patient, 5 vials, 3 treatments, a significant increase in volume with only 5 bottles of Sculptra spread over 3 treatments, and you see average, symmetrical, and she still looks like a woman, and nothing overcorrected or highlighted more than the other. Side view, restoration of the anterior projection, so improvement of the jawline, injection in the temple, site-specific. It's very simple with collagen stimulators. Temples, deep medial cheek fat on the bone, piriform aperture, behind the muscle, jawline. Those specific points make look the whole face different, as well in projection as in contour. And here another view from the side. And of course, if you're getting older, the time and the amount of product that it takes with anything is contingent with the quality of the tissue. So in an older patient, you have to do more, but it still works. So the number of treatment is dependent on the total volume loss. The older you are, the more volume you lose, the more treatments you do. The amount of product that we use during a treatment is just related to the surface that you cover in one treatment. 0.3 milliliter per square centimeter. This is like 10 square centimeter, so that's 3 milliliters of a 9 ml dilution, so it's 1/3 of a vial. And that is often the way that I divide and start with these treatments. So I use 1 vial, put in 6 water, and 3 lidocaine, have 9 ml, and I draw up 3 syringes of 3 ml. I put 1 syringe here, 1 syringe in the mid face, 1 syringe in the lower face. So 1/3 of a vial, 1/3, 1/3, and then on the other side too. In a young patient, it may be enough. Maybe you have to do the next time half the amount the second time, and then it's okay. If you're getting older, you may have to do it 2 times. If you're like 55, maybe you have to do it 3 times, but relatively the amounts are small for the amount that volume that you can create with collagen stimulation. So, crucial to realize, collagen stimulation is not immediate filling, not immediate correction. Never overcorrect. Don't go on till you have a visual satisfaction, because that's what you do with dermal fillers. You get what you see. This is you just go into the target area. If you have an area of 3 square centimeters, you inject 1 milliliter there. You spread it out with a little pressure, and that's it. Even if it's still flat, you leave it because you have to wait for the stimulation. Typically every 4 to 6 weeks. A typical regime of treatment in a cosmetic patient, in a young patient, mild aging changes or facial enhancement, 30 to 45 years, 1 to 2 sessions. In the moderate changes, 45, 63, and in the severe patients, HIV patients or patients 60, 70, older, you may have to do more, but still, relatively to immediate fillers or dermal fillers, it is something what is important. You have to consider that even this patient, if you want to correct her hollowness here and her temples, and the temple here and a little bit here and a little bit on the chin, that if you calculate that, and there are all kinds of tables to calculate that from anthropological and forensic medicine, that you already calculate giving back 20, 25 milliliters. Imagine that you have to do that with an instant filler. That means 20, 25 syringes of a hyaluronic acid, and then maintain it every 8 or 10 months. So collagen stimulation is really cost effective and very potent in giving panfacial augmentation in larger volume and also in younger patients. Again, this is how to describe how to assess the face. We're going to see that during the demo, and I'm almost done. I had 10 minutes, so I just keep talking because I think I still have 4, right? I saw 10, how much do I have? 4. So, summary, site-specific, temples, cheek, mid-face, piriform aperture, jawline, mandible. Don't cover the whole face. If you do these areas, the whole face will look better. That positive effect, that cascade effect. You can combine it with a little bit of subdermal volume, the little crosses, if you want to give a little balloon or roundness to a face, which is good in a woman, but don't do it in a man, because you saw what happened if you do it in a male face. And some things don't need to be fixed. Thank you.